Welcome to the part 2 of asthma, which is acute asthma exacerbation. And I'm going to be covering the management of asthma, rapid severity assessment, secondary severity assessment, first aid for acute asthma, and how are we going to manage the patient according to the severity of asthma. In previous video, I have covered the diagnostic approach to the asthma and the basic management of stepping up and stepping down therapy of asthma and when we are going to review the patients of asthma, specialist consultation referral points. So if you want to watch that, please watch my previous video of asthma. So starting with that, acute asthma occurs in response to certain trigger. This can be a viral infection, viral respiratory infection, or any irritant that has aggravated the asthma symptoms. So when the patient comes to you with acute asthma exacerbation, we are going to give him the first aid for acute asthma. So first aid for acute asthma can be given at home. Patients of asthma are given the written action plan so that they can take action while experiencing the acute symptoms at home. So all patients with asthma should have a written action plan given by their GP, and they can have the salbutamol 100 mg for actuations and repeat after 4 minutes. Whenever the patient sees first signs of exacerbation, he is going to be administering himself the short acting bronchodilator. The alternate drug can be terbutaline or budesonide or plus formoterol. If the symptoms are escalating, despite the salbutamol, we are going to refer the patient to ER, or he should go to ER. When the patient comes to you with the ER, we are going to first give him a rapid severity assessment. In rapid severity assessment, we are going to check certain things. If the patient is experiencing mild symptoms of exacerbation, severe asthma exacerbation, or life-threatening exacerbation. So mild exacerbation, the patient so in mild to moderate asthma exacerbation, the patient would have all of the following symptoms. Like patient can walk and he can speak whole sentences in one breath, and SpO2 would be more than 94%. But if the patient has severe asthma as exacerbation, so any of the following features would be present. That is, the patient would be unable to complete sentences, and we are going to assess any excess accessory muscles use. That is tracheal tug or recessions or abdominal breathing, and the SpO2 would be 90 to 94%. But if the patient has life-threatening asthma exacerbation, the consciousness would be reduced. There would be collapse. The patient would collapse out of exhaustion. The absent breath sounds would be absent or very decreased. Poor respiratory effort. The patient would be experiencing exhaustion or cyanosis can be there, and SpO2 would be less than 90%. So this would be under the life-threatening exacerbation of asthma, and this is the rapid severity assessment which we have to do when he first enters in the asthma in the ER. So at presentation, we are going to give the patient a rapid severity assessment, and then we are going to start the initial management. Then we are going to go towards the secondary severity assessment to determine the ongoing treatment, the correct if the treatment is right. So we are going to check the ongoing treatment by secondary severity assessment. So what is the secondary severity assessment? In secondary severity assessment, we are going to assess the patient in a little bit detail. If the patient has mild to moderate, all of the following symptoms would be present. That is, the patient would be alert. He can finish a sentence. He can walk, and respiratory distress is not much severe. That the patient do not have to use accessory muscles. Respiratory rate is normal. Heart rate is normal, and V's can be there, and SpO2 is more than 94%. ABG is not indicated in this case, and FEV1 by PEF ratio is more than 40%. In case of severe In case of severe asthma exacerbation, the symptoms, the patient would be alert, and in speech, the patient would not be able to complete the sentences, and patient is having difficulty in lying down, lying flat, and sitting. The patient is having difficulty in lying flat, so the patient is sitting upright so that he can breathe easily. And there would be use of accessory muscles, respiratory rate would be increased, that is tachypnea, tachycardia would be there, V's would be there, and SpO2 would be 90 to 94%, and ABG may be indicated according to the severity, and FEV1 by PEF ratio would be less than 40%. In case of life threatening, the patient consciousness would be decreased. That is, the patient would be drowsy or he would be conscious. He can use single words because the patient has severe shortness of breath, due to which he cannot say sentences. Patient would be collapsed and exhausted. There would be severe respiratory distress, uh, tachypnea, bradypnea due to exhaustion, arrhythmia or bradyarrhythmia can also be there. Silent chest. There, this is a very bad sign for asthma, because there is a decreased air entry. The SpO2 is less than 90%, and clinical cyanosis can also be there. PaO2 is less than 60%, PaCO2 is more than 45%, pH is less than 7.35, that the patient is undergoing acidosis. And spirometry cannot be performed in this patient, so we cannot measure the FEV1 by PEF ratio. So, if the patient comes to you, we are going to assess the risk factors for asthma related death, and X-ray is indicated if the patient X-ray is indicated in the case of acute exacerbation when patient has pneumonia, atelectasis, pneumothorax, or sudden deterioration on asthma in asthma. Most important indications for severity of asthma are general appearance, mental status, and work of breathing. These are the most important indicators for checking the severity. Now coming towards the management of acute exacerbation of asthma. So short acting bronchodilators are the mainstay treatment for acute exacerbation. Let me again repeat that at first the presentation we are going to do the rapid severity assessment and start initial management. Then we are going to give him the secondary severity assessment and determine the ongoing treatment. So if the patient has mild to moderate exacerbation of asthma, we are going to give him the salbutamol through PMDI spacer, and corticosteroids, oral corticosteroid would be given within first hour of presentation. In cases of severe asthma, initially we would start with salbutamol and ipratropium through PMDI. Oxygen therapy, if the PO2 is less, is the saturation is decreasing, oral steroids would also be given. And if the patient cannot breathe through a spacer, intermittent SABA, these short-acting bronchodilators would be given through intermittent nebulizer. Now, if the patient has life-threatening acute exacerbation of asthma, so first of all, we are going to consider anaphylaxis. This can be a differential diagnosis with life-threatening asthma. So we are going to run an initial rapid assessment, and we are going to immediately transfer the patient to hospital, and immediate treatment is given, and that is bronchodilator with continuous nebulization. In mild to moderate, the patient is given bronchodilators with PMDI, and moderate, if the patient cannot use spacer and he cannot breathe through spacer, we are going to be giving intermittent nebulization. But in life-threatening asthma, the bronchodilators are given with continuous nebulization. There would be supplemental oxygens, and steroids would be given through IV route within the first hour. So this is the initial management. Now we are going to do the secondary assessment of the patient, and if the patient, we are going to check We are going to check in secondary assessment that the patient's ongoing treatment is right and the patient is responding to the ongoing treatment. We are going to assess that in secondary assessment. So if the patient is not responding well, we are going to give him the IV magnesium sulfate. This can be required if the patient do not respond to initial treatment. And the main thing for IV magnesium sulfate is that the sickest patient would be benefited by it the most with magnesium sulfate. So the sickest the patient, the more the benefit with IV magnesium sulfate. The high doses of salbutamol may also be required to be given because of the severity, but high doses of salbutamol are associated with hypokalemia and magnesemia and cardiovascular events like MI, prolonged QT. So we are going to monitor the patient for that. Magnesium sulfate is associated with hypermagnesemia, and hypermagnesemia can cause loss of deep tendon reflexes, muscle weakness, and muscle weakness can also include respiratory muscles. So it is very crucial to monitor the patient when he is on magnesium sulfate. What are the additional treatment options for asthma exacerbation? Adrenaline is given when the patient is unresponsive, there is poor respiratory effort, and the patient cannot inhale. And we are seeing that the patient is going under arrest or he is peri arrest. So we are going to administer the patient adrenaline. IV salbutamol is given when the sickest patient is given in the sickest patient in whom the nebulization is impractical. So we are going to give the IV salbutamol. Ventilatory support is also given if the patient is undergoing the respiratory failure. Corticosteroids are very important, and these are given in all the cases of acute asthma in adults and children 6 years or older, except mildest of the cases. If the exacerbation is mildest, we are not going to administer corticosteroid, but in other all other cases of corticosteroids are given in all the adults and children 6 years or older. In all cases of severe acute wheezing in children 1 to 5 years. All the cases of acute asthma in children 6 years or older are given steroids, but in children 1 to 5 years, if the acute asthma exacerbation is associated with wheezing, so we are going to give these steroids. Oral steroid is prednisolone or dexamethasone, and IV is hydrocortisone. So, if the patient cannot tolerate or he is not able to take oral therapy, we are going to shift towards the IV therapy, or the patient is not cannot take oral therapy. We are going to give him the IV therapy. Consider total treatment course of 5 to 10 days in adults and 3 days in child while discharging. So, hospitalization and discharge, any feature of acute life threatening asthma or acute severe asthma that did not respond to initial treatment, we are going to hospitalize the patient, right? And what is the criteria if we are discharging the patient? Consider we do not discharge the patient if he is required to have SABA more frequently, that is with more than 4 hourly gap. We are not going to discharge that patient, or the patient is not able to lie flat. So patients with severe asthma and adverse psychosocial factors are at increased risk of asthma related death. Referral or a specialist review. A specialist referral is indicated when there is first presentation of asthma with acute asthma that required hospitalization, poorly controlled asthma, near fatal or brittle asthma, that is he gets sudden and severe exacerbation. So he is going to have the referral for a specialist for life. So that sums up our asthma topic. In next video, I will be covering the pneumothorax. So stay tuned with me if you like my videos, and if you like to watch my videos, kindly like and subscribe my channel and share with your colleagues. Thank you. That's it. If you have any feedback or regarding my videos, please comment down below.